Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guest today is Dr. Mark Schuenke. Dr. Shanki is a PhD and is the Professor of Anatomy and the Associate Chair of Biomedical Sciences at the University of New England College of Osteopathic Medicine. Dr. Shanki is a very skilled and entertaining educator, and I know that you will find my conversation with him today where we discuss differentiation of lower extremity peripheral nerve entrapments from radiculopathy to be an extraordinarily beneficial segment for you to integrate into your clinical practice. It is always a pleasure when I get the chance to interact with Dr. Shanki, and I always learn from him, and I'm sure you will. So please enjoy this great conversation we have about radiculopathy and lower extremity peripheral nerve entrapment.
All right, everyone. I'm here with Dr. Mark Schuenke, who is an anatomist up in Maine. And Mark, tell us how you got into anatomy. And we met a long time ago. You've been working with the Association of Extraordinary Nerve Surgeons for, 15 years, maybe?
Yeah, that's probably about right. Yeah, it's good to see you, Steve. So I got into anatomy kind of in a circuitous route, really. I was always fascinated with physics, actually, growing up. I started out my academic career thinking I wanted to go into engineering, actually. I did a lot of math, a lot of physics. But as I got further along in the coursework, I don't know, it just wasn't connecting with me. I did okay grade-wise, not stellar, but I wasn't failing either. And all the while that I was kind of slogging along in it, I was a gym rat. I loved to be in the gym, focused on, how my body works, how nutrition plays in with exercise and all those different things. And so I started to kind of explore ways that I could pair those two things, pair the kind of physics with the human body. And that led me into some kind of biomechanics and exercise physiology coursework that I did for my master's program. And while I was there, I got a taste for higher education, for academia. And I really enjoyed teaching. A little bit of a backstory. Feel free to cut it out if it's not good for your audience. But my parents are both teachers, and I came from a long line of teachers in my family. And I always swore up and down that I'd never be a teacher because I saw how much effort they put into things and, how little reward they got back from it from a financial standpoint. And so I swore up and down I'd never be a teacher. And then I got into my master's program and started to teach just to make a little bit of money on the side. And I discovered, wow, this is really in my blood. I really love this. And so that led me to go on for a PhD because I wanted to teach at a higher ed level, but I didn't have enough education to do that, right? So I needed a PhD. So I went for a PhD in biology, and that's actually where I was introduced to anatomy on a deeper level. Like I knew anatomy enough to, know how it worked with health and biomechanics, but I had never taken a gross anatomy course. And that was one of the first things I took when I was there. And I discovered that it's a really intimate way to get to know the human body, and it's something that most people really shy away from. I mean, I understand that there is a grossness factor, not in the gross anatomy sense, but in the disgust sense. And I can appreciate how some people shy away from it. But if you can get beyond that, you can just appreciate the beauty of the body in a whole new way. You, as a surgeon, would appreciate that, you need to do dissection to be able to appreciate the spatial relationships that are inside the body. And so that's how I first got introduced to the anatomy, and I realized that a lot of my classmates were struggling with the material, and I just had this natural affinity for it and a natural kind of aptitude for it. So I pursued that direction. I discovered that from a teaching standpoint, it's a lot of fun because it's more interactive, it's more hands-on. You're working with just a few students at a time as opposed to lecturing in front of them all of the time. I mean, I like to lecture too, but it's nice to switch it up. And that led me to seeking out opportunities to teach anatomy. And I knew I wanted to teach at an osteopathic school because osteopathic schools just focus on anatomy a little bit more than the other allopathic schools tend to do. And that's how I ended up here in Maine at the University of New England College of Osteopathic Medicine.
That's great. Now, everything that's changed over the last 15, 20 years, almost every industry, every subset of academia because of advancements, that type of thing. A lot of people think about anatomy as this, well, it hasn't changed much, has it? But it really has in a lot of these platforms now that are being used for teaching these 3D animation things. What's your thought process on that as far as education? Because some people really, like you said, some people just have great affinity for anatomy, and some people who are very bright struggle like hell with.
Right. Yeah, I mean, I can appreciate those different modalities of teaching, but I feel like they are more kind of supplementary. I don't feel that they are adequate for learning the anatomy, especially at the level that you need for like going into surgery or something like that. Or I would argue even other types of medicine, anything that's going to require a higher level understanding of how the body's put together and the anomalies and things like that. Because those programs just don't appreciate the variability there is from one person to the next. I mean, you need to appreciate the anomalies. And even if they're not true anomalies, there's just a variation in courses of nerves. I mean, you know this from your surgeries. The nerve's not always where you expect it to be, or sometimes there are 3 branches where you'd expect there to be 1 and things like that. And you appreciate that in a way that you wouldn't get with, computer simulation.
Yeah. No, I didn't mean to imply that I was looking at these platforms more as an adjunct to the real time spent in the cadaver lab, because that's where you see the variability.
Absolutely. Yeah. And pathology and, results of surgery, sometimes good, sometimes not so good. But you're right. They're fantastic for an adjunct. We have students oftentimes with an iPad or some other tablet in the lab, like looking at the simulation while they're also working on their cadavers, and the ability to, let's say, just turn on and turn off layers so you could just see the nerve course and then add in, the bones or the muscles, really is helpful for the students. It's just, again, I would caution against using it as your sole method for learning the anatomy.
No, I agree. But I think there's, people have different methods of learning, and some people are very auditory, other people are much more visual. But anatomy really is a very hands-on thing. And that, I think what gives you an appreciation as a surgeon is that, you went through all of the gross and lower extremity anatomy and all of these things, but then you start seeing all of these things in vivo rather than in a cadaver. And then when you do get back to a cadaveric lab, which is a blessing because it just kind of brings everything together conceptually. So I encourage people to, continue trying to get to the cadaveric labs as much as they can, especially if they're surgeons, because it just, reinforces what you've observed clinically and intraoperatively for a period of time. Is there any, I know you're fantastic at lower extremity anatomy, of course. You've been hanging around with us at the Association of Extremity Nerve Surgeons for longer than most people could tolerate. And I give you all the accolades for that. But is there what's like one of your favorite areas of anatomy besides lower extremity? If that is. Yeah.
Yeah, no, I love teaching the entire body. At the University of New England, we do a full dissection course, and there's not one part that I don't enjoy doing. There are some that are a bit of more of a struggle than others, particularly like the Peroneal region is challenging for the students to understand, and so that's a unique challenge as a professor to get them to appreciate the different spatial relationships in that tight little bowl of the pelvis, especially because there's so much, pathology and atrophy and surgeries that are occurring down there before, donors would come into our lab, because most of them are, 60, 70, 80, 90 years old. So a lot of, menopause and pathologies and things. But I think the area that I probably enjoy teaching the most is in the head and neck, doing the cranial nerves, following them through the different, foramina in the skull, and then layering in the functions and helping students to appreciate how, this one nerve, let's just say the facial nerve, for instance, has so many different components to it. And depending on where there might be a lesion, you need to, play detective and figure out exactly, what functions would be lost. How is your patient going to present if the lesion is here versus, if it's over here? Is just really a lot of fun. And I think I would say that's probably my favorite. Yeah.
Well, that brings a question up. Could we talk about neuroanatomy and the variability of neuroanatomy in lower extremity? It's all over the place. What about in the head and neck? Do the cranial nerves have a real high level of variability in your cadaveric experience, or are they more central?
That's a good question. I don't know that I've ever really thought that through, but now that you're bringing it up, I would say that I think there's less variability, at least within the skull. The foramina are pretty well set. Now, there might be a shape difference in the foramina, or there might be a slight, jog that you might not expect. But in terms of branching patterns within the skull, it seems to be much more conserved than, if we say, down by the knee and below, in the area that you like to play in. It seems more consistent.
Interesting observation. But we're going to talk about what I think is one of the biggest conundrums for people that deal in the lower extremity, regardless of specialty, and that is what's coming from the low back versus what's coming from the lower extremity. And you gave this presentation back at the annual meeting for the Association of Extremity Nerve Surgeons in November of 2023. And when I saw that lecture, all your lectures are great, by the way, except some of your animations with my head on it. But other than that, I think your presentations are fantastic. But when I saw that presentation, I said, we need to get this out to more people rather than just the group that was there at the meeting. So we'll do a little screen share. You want to take us through anatomy of the low back versus lower extremity? And I think it'd be great.
Sure, I'd be happy to.
Okay.
Just get this going here. Okay, so first things first, what are you seeing? Are you seeing full screen, or are you seeing the notes view?
No, I've got the full screen.
Perfect. That's what I was hoping for.
I have to stop and commend you right now. You're the first guest that I've had that actually just popped it up and it worked magically. So you have obviously paid homage to the IT gods.
Well, we for over a year had to teach this way. During the pandemic, we had to figure out how to teach anatomy exclusively via Zoom, which I hope we never have to go back to. But a lot of my Zoom experience has come from that, as actually I'm sure most people's has.
Cool.
But anyways, so you've got the image. You can now see the laser pointer, I hope.
I certainly can.
Okay, well, let's go ahead and get started then. So, over the past several years, as you've said, spending time around, you know, people from the Association of Extremity Nerve Surgeons, as well as my med students and the medical community, I frequently get asked how you differentiate between radiculopathy and peripheral neuropathies. As I'm sure radiculopathies and peripheral neuropathies can look and act very similar, but they have very different etiologies and very different treatments. I mean, Steve, for you and most of your colleagues, peripheral neuropathies are in your wheelhouse and radiculopathies are completely out of your scope of practice. So we need to be able to differentiate between the two. And so I put together this little overview and, share it with you down at Fort Worth last year. And I'm happy to do so again with you today. So now I need you to recognize, of course, that I am an anatomist by training. So, my patients are 100% compliant. They never complain. And so I'm at liberty to take a different view of diagnostics, right? It's a low level, low cost kind of in-house anatomical approach. I'm sure any interventional radiologist that might listen to your show would have an extremely different approach from this. But for me, I guess you complimented me too soon here. There we go. For me, on the face of it, the difference between radiculopathy and peripheral neuropathy is simple. It begins with anatomy. Structure equals function. Right? Besides, as an anatomist, if we don't start with the anatomy, I don't get to show off my cool dissections. So here we see a donor in the prone position. Obviously, the skin and superficial fascia have been removed. The trapezius and latissimus dorsi have been removed as well. You can see the iliocostalis from the erector spinae muscle group kind of radiating out onto the ribs. More medially there, the other paraspinal muscles have all been removed, and we've laminectomized the entire vertebral column. So you can see this kind of tan midline structure right through here is the dural sac. And if we zoom in on that, here you can see the spinal cord. It's still encased in dura, but if you look closely, you can make out different components that will contribute to the spinal nerves, and I will highlight those as we move along. But if we first take a look at the microscopic level, here we see a cross-section through the spinal cord and the spinal nerve over to the side there. And if we zoom in on this little region indicated by the box, you can see a ventral horn, right? That's home to those motor neuron cell bodies. And we can see a ventral horn down here, which is going to be containing the axons from sensory neurons. You can also see, the dura mater here, which is going to come off the cord and protect the spinal nerve root as it becomes continuous further laterally with the epineurium. In the cadaver now, I've highlighted in green with the help of Adobe Illustrator the ventral roots, right? So again, these are going to contain axons of alpha motor neurons that we just saw residing in the ventral horn, headed down to, who knows what, flexor hallucis brevis or something like that. By contrast, here in yellow now we see the dorsal roots. These are containing axons of pseudo-unipolar neurons, bringing sensory innervation from the periphery. So at the bottom of the screen, you can see the dorsal root. It's carrying axons of sensory neurons from their cell bodies in the dorsal root ganglion into the dorsal horn. Right? And if we magnify this region here, now the histologic image could actually show us the dorsal root ganglia. So this is the location of those cell bodies from the sensory neurons, right? So pain receptors or touch receptors all the way down to the foot are going to come up through nerves, such as the sciatic nerve, and bring their those signals to the neuron cell bodies in the dorsal root ganglion here, and from there through the dorsal root and into the dorsal horn. Note also here that the ventral root is passing adjacent to that dorsal root ganglion without any interaction. There's a distinct separation there. Mm-hmm. On the cadaveric image, you can see the dorsal root ganglion right there, highlighted in red. The axons of those ventral roots are passing just anterior to it. So again, this is a prone specimen. So the posterior is closer to the screen, and a little deeper into the screen would be the ventral side. If we continue a little further laterally, here now we see the spinal nerve, right? So this is where those sensory nerve fibers from the dorsal root and those motor nerve fibers from the ventral root are finally going to flow together into the same epineurium. So in other words, we have a mixed nerve for the first time. These spinal nerves are going to pass out through the protection of the vertebrae, through the intervertebral foramen, and that's where they might get entrapped by osteophytes or zygapophyseal joint capsule hypertrophy. It might get entrapped. It might get entrapped. It might get irritated there. Once outside the vertebrae, those spinal nerves will then split into dorsal and ventral primary rami. Dorsal we see here in purple, ventral in orange, respectively. Those dorsal primary rami are going to innervate the muscles and skin that develop posterior to the transverse processes, so things like those paraspinal muscles. The ventral primary rami will innervate the muscles and skin that develop anterior to the transverse processes. So all the things in the lower extremity, the things that we really care about, are going to be innervated by those ventral primary rami. So finally then, here we see all of those components from the roots all the way out through the rami. If any of these components seen here are compromised due to anything, disc herniation, osteophytes, Z-joint hypertrophy, really any cause, it's considered a radiculopathy. Okay. All of these components contain neural elements from only one spinal cord root level, and that is the crux of a radiculopathy. Any lesion of the dorsal or ventral root, the spinal nerve, or the dorsal or ventral primary ramus is a radiculopathy, and therefore radiculopathies might be sensory only, they might be motor only, or they might be mixed, but they're only going to have deficits from one spinal level. Okay. Now, in some places, these ventral primary rami will merge with ventral primary rami of other cord levels to form a plexus. Plexus just means braid in Latin, so you can imagine kind of the interweaving of nerve fibers from multiple cord levels. And unless I'm mistaken, much of your listening audience is going to be interested in structures downstream of the lumbosacral plexus, so that's the one that we've highlighted here. So on the right, we are seeing two dissections that collectively mimic the picture that's on the left there. So top right is a partial dissection of the lumbosacral plexus on a hemisected specimen. Now you can see the bisected sacrum is right here. You can see some of those ventral primary rami of the sacrospinal nerves emerging from the sacrum and converging on a plexus. They are unnaturally colored here using Adobe Illustrator again. And they are basically mimicking what we see in this image on the left here. We're seeing the convergence of those sacral ventral primary rami into plexus, and then from there we'll see it diverging into some different nerves. On the bottom right, you see a posterior view, and we're seeing things like the sacrotuberous ligament right here, the piriformis muscle right here. And emerging inferior to that piriformis muscle, we are seeing a couple of nerves that have just come out of the greater sciatic foramen. The one on the right, the larger one, is the sciatic nerve. The one on the left is the posterior femoral cutaneous nerve. Both of these, of course, are carrying multiple cord levels. The sciatic nerve, L4 to S3, posterior femoral cutaneous nerve, S1 to S3. And, of course, virtually all of the nerves reaching below the knee are branches of this sciatic nerve. So what we're going to do is think about how to tell if we're looking at a radiculopathy somewhere in the L4 to S3 region, any one of those spinal nerves or nerve roots, or if we're looking at a peripheral neuropathy of either the sciatic nerve or one of its branches, right? It could be anywhere from the piriformis to the distal foot. There are places where those different nerve branches might get entrapped. And so this is where we get into diagnostics, which again means I need to remind you that I am an anatomist. So I do things a little bit differently, right? Here comes your favorite part, Steve. When you are reaching for your little pinwheel, I'm getting out my scalpel, right? When you are grabbing your EMG machine, That's when I'm getting out my bandsaw. And by the time you're referring for a PET scan, I'm just reaching for the bourbon because you win. I can't compete with that kind of technology. But if you're looking at a low cost, in office, step one diagnostic, you begin with the anatomy. Right? And conventional anatomic wisdom suggests you begin with a dermatome map. So this is the area of skin innervated by the sensory axons of a single spinal nerve. It theoretically should help us identify the radiculopathies. The problem is there's a lot of disagreement amongst dermatomal maps, as you can see in those three classic maps on the screen there. You'll notice that there is a lot of variation there, but you'll find one of these three maps in most anatomical texts, most surgical texts, but there's just so much disagreement there. And we don't really have time to investigate those differences, but this chart here highlights some of the basic differences, so I'll leave that for your reference. In 2008, I believe it was, an evidence-based map was developed representing the most consistent tactile dermatomal areas and leaving blank regions where there's either considerable overlap or just too much variability. This was followed up in 2011 by the international standards being set for specific sensory points for testing along those dermatomes. So of interest to your listeners would be things like L4 is typically best tested at the medial malleolus. The L5 dermatome is most accurate on the dorsum of the third metatarsal phalangeal joint. S1 is most accurately tested at the lateral calcaneus. I should be noted that this same group also came out in about 2017, I think it was, and conceded that medial malleolus can be variable for L4. So that one is still a little up in the air, but those others are very consistent. Along with this, it's important to realize that adjacent dermatomes are going to overlap to a variable extent. So there may be like a numb patch in the center of a dermatome with burning around the edges of the root distribution. And that tells us that, dermatomes might be helpful to an extent, but they aren't enough, right? So we need to add something else. And so from an anatomical standpoint, what you would add on top of a dermatomal map would be myotomes. Those might be helpful. So here we see kind of a rudimentary list of myotomal territories. This was provided by the National Institutes of Health. And not surprising, the ankle dorsiflexors are attributed to L4. The L5 is mostly eversion and hallux extension. S1 is getting your plantar flexors. But much like the dermatomal overlap, very few muscles in the body receive motor axons from only one cord level. Most receive at least two. Certainly that's true of all of the muscles below the knee, as demonstrated by this chart here. And of course, those are the ones that you're interested in. Similarly, here we see a study in which patients were undergoing lumbar surgeries in which the nerve roots were exposed. And so they took this as an opportunity to place EMG electrodes in the muscle groups that were generally accepted to be innervated by those nerve roots. A neural stimulator was then placed directly on the nerve root sleeves, and EMG activity was recorded. And you're seeing the results on this slide here. Again, you can appreciate that even the tiny little abductor hallucis muscles are receiving motor axons from multiple segments. So dermatomes and myotomes both have probably too much overlap to use as diagnostics for radiculopathies by themselves. So what else can we use to identify radiculopathies? Starting with a big picture of symptoms, basically, because dermatomal and myotomal overlap so much, radiculopathies don't have focal symptoms typically. It tends to be more subtle manifestations down a dermatomal stripe, whereas peripheral neuropathies will be more likely causing pain or weakness or possibly atrophy specifically in a distribution area of a single peripheral nerve, like the deep fibular nerve or the medial plantar nerve. A chief complaint for patients with lumbar radiculopathy typically is going to be pain. It might be sharp, it might be throbbing, it might be burning. Generally, there is a lumbar pain component coupled with symptoms in the limb, such as those that we see on this slide here. Sensory nerves are more sensitive to compression, and therefore in a radiculopathy, those sensory symptoms are generally detected first. And you can see on this slide, paresthesia and pain are amongst the most common symptoms. If the pain is from a herniation, the radiculopathy is a herniation, you could perhaps provoke it further by asking your patient to bend forward or to increase their intra-abdominal pressure by coughing. If the pain is from a spinal stenosis, you might be able to provoke it by having your patient take a walk. So those are just kind of some generalities. So now if we look at each specific level, L4 is where the lordosis is going to start to become most pronounced, that lumbar lordosis. And so it's usually here or below that radiculopathy is more likely to be due to a herniation. And it's going to present with sensory symptoms on the medial leg, kind of in the distribution of the saphenous nerve, right? So how do we differentiate between L4 radiculopathies or just a saphenous neuropathy? Well, first off, if there is a motor component, a deep tendon reflex of L4 may be either depressed or absent. But even better way to test it than that, the test proven to be most diagnostic for an L4 radiculopathy is the single leg sit to stand test, which is what you're seeing in that GIF on the lower left there. Because the quadriceps receive a large motor contribution from L4, this test is going to demonstrate weakness in the muscle group as well as in the iliopsoas that wouldn't be there if it was a saphenous neuropathy. Now, obviously, it goes without saying that if the L4 radiculopathy is a purely sensory syndrome, this DTR and the sit-to-stand test aren't going to show any deficits. So in that case, your best bet is really determining whether it's a radiculopathy by asking them to lie down, which may lessen the symptoms, asking them to bend over, which might exacerbate the symptoms. And beyond that, you can also look on the plantar foot, especially on the medial side, right? The saphenous nerve is going to just barely reach the plantar foot, if at all. But the medial plantar nerve also is going to have contributions from L4. So an L4 radiculopathy should impact the plantar foot to a larger degree than just a simple saphenous neuropathy would. Contrast.
Mark, let me interrupt. That actually is a very important clinical note. Would you say that again for everybody? Because I think this will help them clinically, right?
Absolutely. Yeah. So if you're differentiating between a saphenous neuropathy and perhaps an L4 radiculopathy, you need to really consider the distribution patterns, right? And I know I just spent a little bit of time saying how the dermatomal maps are largely useful. They're helpful to guide you, but it's not sufficient. I think in this case, it is particularly helpful to look at the peripheral nerve maps, which is what we're seeing here, this kind of colorful map provided by Dr. Gray, some century ago. You can see in pink is the saphenous nerve distribution, and it comes down that medial leg, but really doesn't touch the foot much at all, right? Meanwhile, the medial plantar nerve, which is getting a large portion of the plantar foot here, is also going to have an L4 contribution. And so if your patient has some deficits or some pain or paresthesia on that plantar foot, it's likely to be L4 radiculopathy as opposed to being a saphenous neuropathy.
Okay, that's a good point. I would add, and one thing that I've seen clinically regarding the saphenous is that it does definitely go out towards the dorsal medial aspect of the first metatarsal phalangeal joint. We've seen it injured a lot in bunion surgery, and you can come up proximally. The saphenous is pretty easy to find. Do a little peripheral nerve block, and then all of a sudden that bunion or repaired bunionectomy patient now no longer has pain. So. But yeah, I think that's a great point.
Yeah, that's good. And you said the dorsal side, right?
Yes, correct.
Right. Yeah, and so again, I would not expect it to go to the plantar side, but you're right that there is some variability on how far it reaches out onto the dorsum of the foot. In this map by Dr. Gray, you see that it really doesn't extend out very far onto the dorsum at all. But you're absolutely right that sometimes it will extend out further onto that first digit.
And now, a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBARRETT at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today.
So if we contrast that L4 radiculopathy with an L5, the L5 is going to be the most common radiculopathy in the lower limb. It's quite commonly due to disc herniation, again, because that's where that lumbar lordosis is the greatest. And it will present with paresthesia along the lateral leg and anteromedial foot, kind of along the distribution pattern of the common superficial and deep fibular nerves, or peroneal nerves, since I can't break you podiatrists of your old habits there.
You know, I'm the biggest hypocrite in the world. I'm the biggest hypocrite in the world because I hate the way you guys changed common peroneal to common fibular. But at the same time, I can't convince the profession to get rid of the nomenclature of Morton's neuroma. So,
Yeah, those eponyms are tricky. And as you well know, many of your colleagues and many of my colleagues as well aspire to have things named after themselves. So we can't really get rid of the old eponyms and introduce new ones.
Right.
So it's tricky territory. But I couldn't resist the urge to jab you on that one.
Oh, no, I take it. I just feel a little hypocritical because I still like common peroneal. And part of that is because that's, it's not just me, but it's like an insurance company doing a peer review or, billing and collections matters and those types of things. It's like, well, they don't have the new nomenclature yet. So
that's true. That's true. I will say I was publishing with one of your colleagues last year, and your colleague wrote wrote peroneal in there, and I thought about changing it, and I said, you know what, I'm just going to let it ride. And then we sent it in, and the reviewers' comments back were change peroneal to fibular. That's the old term.
And see, that's funny because I actually had a paper, I think it was maybe within 2023, and they said you have to use peroneal because that's the nomenclature that's understood rather than
no kidding.
Yeah, it's like, all right. So, just a little bit of academic schizophrenia.
I guess so. Yeah. So anyways, the L5 radiculopathy oftentimes will be in the pattern of the common superficial and deep fibular nerves. And so it can be differentiated from those peripheral neuropathies by additionally having radiating pain from the buttock down the lateral thigh. They will often exhibit weakness, oftentimes in the extensor hallucis longus and in the lateral compartments. Less commonly, they may also have weakness to inversion and digital extension, as well as ankle dorsiflexion. In chronic cases, you might start to see some atrophy here, especially in the extensor digitorum brevis and possibly the tibialis anterior. They may even have weakness to thigh abduction. So if the gluteus minimus and gluteus medius are involved, which both get a decent L5 component, you may actually want to have your patient perform a Trendelenburg test, right, where you have your patient stand on one limb and look to see if the hip drops. If that hip drops, that's indicative of there being some involvement of either the superior gluteal nerve or L5. Obviously, if there's no deficits down in the area below the knee, you'd be looking more at the superior gluteal nerve. If there's involvement below the knee as well as a positive Trendelenburg, then you're thinking more L5 radiculopathy. Furthermore, you may try to elicit a medial hamstring reflex, so tapping on either the semimembranosus or semitendinosus tendons will elicit a reflex, and you can look for asymmetry of those reflexes. An asymmetry would be suggestive of an L5 radiculopathy. And finally, a straight leg test, as shown in that GIF on the lower left there, should elicit pain in about the 30 to 70 degree range if a herniation is present. And to be clear, the straight leg test is not specific for L5, but again, L5 is the most common disc herniation, so it may be predictive if you suspect your patient might have a radiculopathy. Moving to S1, that S1 radiculopathy is going to radiate to the posterior thigh and leg in the distribution shown in kind of green and brown and that blue there. And commonly, it's going to have paresthesia to the lateral and plantar foot, mostly along the sural and plantar nerve pathways. S1 has motor roots throughout the entire posterior chain, so you may detect paresis anywhere from gluteus maximus, biceps femoris, gastroc, soleus, flexor hallucis longus, plantar intrinsic foot muscles. That S1 deep tendon reflex measured at the Achilles tendon will be diminished. So that calcaneal tendon reflex that we see in the GIF there is something to look for. But this could also easily be confused for a tibial neuropathy, right? So to differentiate there, it's important to look for paresis proximal to the knee. It's also useful to note that even though dermatomes have a lot of overlap and inconsistency that we covered earlier, that S1 dermatome has been shown to be one of the most reliable. So watch for paresthesias on the posterolateral leg in order to help rule out tibial neuropathy.
Thanks.
I didn't really make a separate slide for S2 or S3, even though S2 does definitely have involvement all the way down to the foot. But, an S2 radiculopathy should also have peroneal involvement, not peroneal, but peroneal.
Right.
So bladder control or external anal sphincter function may be impaired, and I think your patient would definitely be mindful of those sorts of things. So it's probably out of your scope of practice to do an anal wink reflex test, but it would definitely be predictive of a mid-sacral radiculopathy. So now let's
You notice I didn't even take that softball and hit it.
Well, I was a little afraid. Maybe you do.
It took a lot of restraint on my part, Mark, to not hit that thing out of the park. But we'll save that for a glass of wine later, for sure.
That sounds good. So if we flip this around now and look at the presentation of common neuropathies in your treatment areas, nearly all of them are going to be branches of the sciatic, right? And so, we'll address individual branches of the sciatic in a bit, but first let's start with the entire sciatic. So that could be entrapped at the piriformis. It could be damaged by a hip dislocation. It could be damaged by an intramuscular injection. Generally speaking, if the damage is from an injection, motor fibers are more likely to be compromised, and those motor fibers of the common fibular nerve are more susceptible than those of the tibial division, just due to their more lateral position in the nerve. Actually, as a matter of fact, the sciatic nerve damage of any origin is estimated to be almost 3/4 of the time, I believe. I believe it's 75% of the time it's more likely that the common fibular nerve is going to be involved than the tibial.
Why do you think that's the case? Just because of anatomical location, or is there a vascular component to it?
I don't think it's vascular. There are a few different factors that I believe play into it, and one is that if you look at the mapping of the nerve roots, well, I guess this is kind of. Let me address that secondarily. First, I think there is a common anomaly in which the sciatic nerve comes out partially through the piriformis muscle. Okay, so here we see the piriformis muscle. I forget the exact percentage, but I feel like it's maybe in the 15% range. Maybe we can check that before this airs. And if I'm dramatically off on that, we can put a little disclaimer in there. But
no,
I think it's.
I think you're spot on there, because I was looking at variability of the sciatic a while back, and there are. I mean, it can have a high division of the common and the tibial even before it gets to the piriformis. I forget the percentage of time, and then one branch can pierce through the piriformis, and then the other branch can be inferior to the piriformis.
And that's exactly where I was going. Yeah.
Go ahead.
It's the common fibular branch that will go through the piriformis. And if that's the case, every time that piriformis muscle contracts, it's going to be clamping down on that common fibular nerve, which, it certainly will lead to, more deficits being shown in that common fibular division. In addition to that, it's just more laterally located. The common fibular is more on the lateral side of the nerve, and so it's at greater risk. It's not as well protected. It's more exposed, again, to intermuscular injections, to contusion. It's just at greater risk. In addition to that, it's interesting. Oh, go ahead.
Could some of it be to the fact that distally it appears, and correct me if I'm wrong on this, but distally it appears that the tibial nerve is a little bit less tethered than the common fibular nerve at the fibular neck. And it's so if you have think of it a piece of rope, right, that maybe was split into two pieces distally, but one has a more freedom of excursion than the other. You could maybe assign some of that to that phenomena, just a mechanical tension issue.
That makes sense. Yeah, it definitely is true in my experience of the dissections that it is more tethered. And actually, I should say that the two theories that I was throwing out there were specific to the gluteal region, but definitely when you follow those nerves further down, yeah, that common fibular nerve is at much greater risk as it's wrapping around that fibular neck, right? I mean, it's very superficial. Any contusion to that side, certainly any fracture of the fibula is going to put that nerve at much greater risk, whereas that tibial nerve is running right down between the heads of the hamstrings, and then it goes right through that soleal sling, and so it's well protected through much of the posterior lower leg, really only becoming exposed again when we get to that tarsal tunnel. So yeah, if I were choosing to be either the tibial nerve or the common fibular, I would go tibial every time. It's just much safer that way.
Yeah.
So it's also kind of interesting to note here that they've begun to map the root contributions, and it appears, if you look at these images on the left here, that the L5 roots take a more anterolateral position, whereas S1 takes a more posteromedial location. And so, again, when we're thinking about radiculopathies versus peripheral neuropathies, and specifically thinking about, this sciatic neuropathy, thinking about the positioning of those nerve roots can really help make sense out of how the neuropathy might be manifesting. So, if the entire sciatic is compromised, you could expect to see paresthesias or paresis really down the entire posterior of the extremity. If just the common fibular portion of the sciatic is damaged, it's going to look very much like a common fibular neuropathy. So it's going to be, a lot of weakness and atrophy. And to differentiate it from a common fibular neuropathy, that's more specifically to differentiate a sciatic neuropathy, that's kind of more proximal to a common fibular neuropathy that is just at, let's say, the fibular neck. Really your best bet is going to be to look for damage, in the posterolateral thigh. Look for paresis, look for paresthesia there. But again, that's less likely than damage at the fibular head or neck region. So let's go there next. I mean, as I just said, that fibular head and neck region is the region where that common fibular nerve is most commonly damaged, just because of just how superficial it is there, right? So in this image here, we see the tibia here, fibula right here. Here is that fibularis longus muscle being peeled back, and you can see that common fibular nerve wrapping right around the neck there before it branches into its various branches. And so it's very susceptible, right? Lesions of that common fibular are going to present as you'd expect, right? Paresthesia of the lateral leg and the dorsal foot, paresis of the ankle and the toe dorsiflexors, as well as the foot everters. It is important to note that lesions of this fibular head and neck region commonly only are going to involve the fascicles of the deep fibular nerve. And again, that's just, I think, because of the positioning of those fascicles within the common fibular. It's also important to note that when the entire common fibular nerve is affected, it's those deep fibular nerve branches that are going to suffer more profound motor deficits. Specifically, that extensor hallucis longus is preferentially going to be affected. Right. So, you might see hallux drop as opposed to true foot drop there.
Right. Let me interrupt you there, because I think that's a really important clinical nugget for people that are watching this, because the EHL is by far the most commonly affected and most early affected muscle innervation if there's a common fibular injury. And they can have almost completely 5 out of 5 normal strength for tibialis anterior and extensor digitorum longus, but they may have a 1 or 2 out of 5 EHL. And so it's a really great muscle to test, because it's like the canary in the coal mine. Mm-hmm. Now, do you think the deep fibular is more affected to the EHL just because it has to course through a couple more septa to get down to it?
That would be my guess, yeah. I mean, it would be interesting to do a dissection of that deep fibular nerve, specifically keeping an eye on the different motor branches. But yeah, just the additional things that it has to pass through, and oftentimes those septae can be pretty tight, would be my guess as to why it's going to be more affected than the tibialis anterior. It's also probably getting its muscle fibers a little bit lower, a little bit more inferiorly, or distal, I should say. And so, there's just more room for potential entrapment before it gets to the muscle. Yeah.
No, that's a good point.
So, if we break down this common fibular nerve into its terminal branches, I use that word terminal loosely because we know that, the deep and superficial fibular do have their own branches further distally. But, we kind of already talked about this in general manifestations of the superficial and deep fibular neuropathies. But again, the deep fibular neuropathies at the fibular neck may lead to weakness and atrophy in the anterior leg, notably those extrinsic dorsiflexors. But neuropathies of either the neuropathies at either the fibular neck or at that extensor retinaculum would mostly impact the dorsal intrinsic muscles. And I should point out that in about 12% of the population, we find an accessory deep fibular nerve which branches off the superficial fibular. And that's going to go to that extensor digitorum brevis. So in that case, that extensor digitorum brevis would be spared, and it could actually confuse your diagnosis. So you need to be aware of this variation. Okay? It's possible that you have a neuropathy of the deep fibular but no involvement, or at least not discernible involvement of that extensor digitorum brevis. You should also.
Where does that usually branch off? Is it before it makes its excursion from the compartment to the subcutaneous space, or do you have an idea on that?
I would have to review the literature. I would guess it's actually after it goes into the subcutaneous space, right? After the extensor retinaculum, it would kind of pop off, and it gives that cutaneous component. And my guess is that there's the motor branch is in there, because that extensor digitorum brevis is, muscle belly is right on the dorsum of the foot. And so it makes sense to me that those fibers, as they're going cutaneously, would also just carry some fascicles that are going directly into that muscle.
Yeah, well, and then there's also, I think, about 17% of the time that the EDB is innervated by a branch of the sural.
Oh, okay. I'm gonna trust you on that one. I need to.
And I may be totally wrong on the percentage, but I know that when Lee Dellen and I were looking at the sinus tarsi innervation, which would then have other branches cutting up off of it, we saw, I think, had reported it in the literature, about 20% of the time we had an issue with the sural innervating the sinus tarsi. And then by extension, those branches would go on up into the EDB. But again, it just reflects that there's a lot of variability.
Did you actually check that with EMG studies to see?
No, that was just clinical observation and some anatomical dissection. So I made that assumption, and that could be completely erroneous, but it appeared that was the case. So I think it just reinforces the point that, because of the difference in neuroanatomy, it can mess up your clinical diagnosis sometimes.
No question. There are always anomalies, and then that makes this so fun and challenging.
Right.
But yeah, most texts will suggest that the sural nerve is exclusively sensory. So if you are able to demonstrate that it's giving motor branches into the EDB, that would be really interesting.
So I think there's definitely some motor component to the sural, albeit it's not supposed to be. It's claimed to be 100% sensory, But again, I'm not sure of that. It's just an observation that we saw, maybe wrong conclusion. But I guess the point of the sural is that, in my experience, it's the most highly variable nerve in the lower extremity. I've seen the sural go all the way over to the medial aspect of the heel with a branch that's like a stirrup. And people will say, they had a complete denervation of the medial aspect of their heel, and they still had medial heel pain. Then you go in and give them a sural block, and all of a sudden it's gone. It's like, wait. And then we've seen that in your lab as well.
Yes, we have. Yeah.
Yeah. So anyhow, sorry to interrupt you.
No, not at all. This is your show, pal.
Well, yeah. Well, that's why I have to let the experts talk.
Well, I don't know. I think you get to call the shots, but whatever. This seems to be working out, and I'll definitely take you up on that one you referenced earlier. Maybe we should have started there.
Yes, for sure.
So anyways, I think I was done talking about the deep fibular nerve. So if we go to the superficial fibular nerve, it's most commonly going to be entrapped as it exits the lateral compartment of the leg to become cutaneous, right? So it's typically going to manifest as paresthesia of the anterolateral leg and the dorsal foot. But it might also get entrapped by the retinaculum at the ankle, in which case only the foot would be expected to experience the paresthesia, not that lateral leg ankle area. I guess I should also point out that rarely there is a motor branch of this superficial fibular that might be compromised at the fibular neck, right? That's not typically the way that it happens, but it's possible. And so, your patient might experience weakness in eversion if that were the case. But again, that's pretty uncommon to get motor branches all the way up at the fibular neck entrapped. If we turn to that tibial nerve, as you're very aware, tibial neuropathies commonly occur in either the popliteal fossa, the soleal sling, or the tarsal tunnel. And the most common presenting symptoms are going to be pain and changes in sensation on the plantar foot. So, I think the place to start there is to use a Tinel test at the popliteal fossa and the medial malleolus. Obviously, if the entrapment's in the tarsal tunnel, the Tinels will be negative in the popliteal fossa. If it's positive in the fossa, entrapment's more proximal, right? So a key component for differentiating tibial neuropathy at the sling versus the tarsal tunnel or distally is the sparing of sensation over the heel. It's another important thing to keep in mind. Those calcaneal nerves branch typically are coming off proximal to the tarsal tunnel, so that heel is typically not going to be affected by tarsal tunnel lesions. If you suspect a more proximal lesion, somewhere in that soleal sling or in the popliteal fossa, test the large plantar flexor muscles, right? Have them perform one-legged calf raises to look for unilateral weakness. Unfortunately, if you suspect that it's in the tarsal tunnel, strength testing really isn't going to be reliable because testing intrinsic foot muscles just doesn't work very well. At least that's what I would assume. You as a clinician might have a different opinion on that, but I would imagine it would be difficult to find weakness in such small muscles.
Well, one of the things I think you mentioned there that is very valuable clinically is if they do a calf raise and you think that you have a lesion at the level of the soleal sling, you can have them do 10 calf raises like they're leaning up against the wall, and then on the 10th have them hold it, and then you palpate, provocate in that area where the soleal sling is. And usually if they have a problem, they're not going to like that too much. That's a very useful clinical test.
Yeah. So I guess, this is something that I'll ask you. So I'll turn this around. You be the expert. I'll be the podcast host for a moment. If the entrapment's at the soleal sling, then motor innervation to the gastrocnemius is still intact, and possibly to the soleus as well. So are you seeing any deficit or any substandard performance in the single leg calf raise when that happens?
Oh, yeah. I mean, a lot of times they can't even come up on it. Now, whether it's due to muscle atrophy versus just, the wicked pain of the entrapment itself, and they're guarding it, I can't answer that. But I will tell you that the tibial nerve, as we've already mentioned, is far more robust and seems to be far more removed from symptomatology in the lower extremity compared to the common tibial nerve. And I think we've kind of laid out why that is. But if you see an atrophy in like the medial head of the gastroc, you really have a very serious clinical condition because the tibial nerve, it takes a lot to mess it up, and it takes a lot to create, from a nerve injury standpoint, it takes a lot of damage to get to that atrophy.
But again, if you're seeing atrophy of the gastrocnemius at all, I mean, that's suggestive of an entrapment or radiculopathy or something more proximal than the soleal sling. You're talking about maybe in the popliteal fossa, maybe all the way up at the piriformis muscle.
Mark, I'm not sure about that because clinically I've had a handful of cases over the years where, patient had some kind of a complication post-gastrocnemius resection, which is done very distal. And they would, for some reason, in my recollection, it always seemed to be medial gastroc that was affected. So are there not more distal motor branches that are affecting versus just proximal? I don't know.
Well, yeah, okay. That's a fair point. Yeah, so many of the motor branches are going to come off prior to the tibial nerve actually entering the soleal sling. They'll come off proximal to the knee even.
Proximal to the femoral condyles.
Correct, yeah. But yeah, I guess your point is well taken that they're further distally, there still would be some motor branches coming off the tibial nerve going into the more distal portion of the gastroc. So yeah, there could be weakness there still, or pain. Yeah, that's a good point. That's why you're the show host. I'll give you back the microphone.
Can I get back to my hosting position now that you've stressed me cerebrally? I'm like in this PTSD moment right now. But
I don't want to do all the work here. I gotta make sure you know what you're talking about.
Well,
we're almost.
That's the good thing about editing, right?
Touche. Yeah. You can make this look exactly how you want it to look. Yeah. I'll be the. So really, just we're coming to a close now. Once we pass into the foot, the pain and paresthesia are really going to follow the routes of the nerves, right? So the medial plantar nerve is going to be most commonly compressed by the abductor hallucis. It's going to result in paresthesias to the medial 2/3 of the foot. The lateral plantar nerve is commonly going to get entrapped, as the nerve is passing kind of between the deep surface of the abductor hallucis and the medial edge of the quadratus plantae, or perhaps just anterior to the medial calcaneal tuberosity, kind of deep to the flexor digitorum brevis there. And in that area, plantar fasciosis or plantar calcaneal enthesophytes might be the cause, or at least an exacerbating factor of entrapment. And again, you're going to really be looking mostly for paresthesia or pain right along the route of that nerve there. So in neither case would you really expect to detect much muscle weakness. And really that takes us all the way out of the bottom of the extremity. So, in conclusion, discerning radiculopathies from neuropathies is difficult and nuanced, right? There's a lot of anomalies. There are a lot of just very similar things. They can both present with numbness or weakness. So you have to keep in mind that radiculopathies usually are also going to involve back pain and generally are going to be less concrete, but will have reproducible effects with postural changes, right? Whereas neuropathies often are worse at night with impact on sensory and motor function to a more specific nerve pattern. Either way, diagnosis is going to require an in-depth anatomical knowledge of nerve branching patterns and anomalies. So when you're in doubt, consult your friendly neighborhood anatomist. I've consulted with several of the surgeons of the AENS group, and I'm happy to help out with your broader listening audience as well. So Steve, I thank you for giving me this opportunity. This has been a lot of fun. And that's where the presentation ends. I don't know if you want to chat further.
I think that, first of all, thanks for taking the time to come on and share this with everybody, because, I know how busy you are and you're taking over more administrative things there at the medical school and that type of thing. So number one, I want to thank you for your time and your expertise. And I think that a lot of people are going to really benefit from this. And they'll probably want to go back and watch this a couple of times because you just get an inordinate amount of great information. And I don't know that it can be assimilated in a one-time event. So, but thank you for all of that. Been fantastic. The one thing that I wanted to touch on was the double crush phenomena, because I think that's a confounder for a lot of people. I can't tell you how many common fibular nerve decompressions that we've done over the last couple of decades where people come in and say, oh, my little back pain has improved or gone. And you haven't done anything even remotely close. So, Upton and McCulvis talked about this, I think it was back in 1973, the double crush. We see this a lot in peripheral nerve cases, pathology. So it could be that they have radiculopathy and a peripheral nerve entrapment. There's no rule that says a human can't have more than one thing going on at one time. I wish that was the case. It would make life a lot easier. But I thought it was great. I look forward. I look forward to getting up there in a couple of months for the advanced course so that we can maybe go look at and revisit some of these things actually in your cadaver lab.
Yeah, I always look forward to you and your crew coming along. It's such a fun group to work with. And, I should say that anyone who's listening to this, if they have questions about this, feel free to distribute my contact information. happy to do questions or, maybe have them into the lab if that's a possibility, or, work with them in whatever way we can to get them the answers they need. It's always fun to work with you.
Mark, thank you so much. I appreciate you. You are always such a great expert in anatomy, and that's really the foundation of everything we do. So thank you so much.
Pleasure. Thanks, Steve.
This episode is sponsored by Savant Cellars, providers of boutique Tier 1 Reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals, and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at savantcellars.com. That is CEVANT sellers.com. Spelunk15.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.